This station in the OSCE is a very, very common one. And again, you can get yourself, basically the common denominator is that you can always get yourself in a tizzy about everything. And you just have to try and make it as simple for yourself as possible. So Breaking Bad News is obviously a ComScale station. There's very little interaction in this presentation in terms of answers and stuff. So I'm sorry for that. If you have any questions at all, please just put it in the chat. And I'm just going to run through to you how I go about Breaking Bad News and how I think, again, in an OSCE, if you have a process in your head, you should go about Breaking Bad News. Okay. And I say if this is hard for anyone, please feel free to just mute me because I know it can be a bit of a sensitive topic. Okay, so what you should know by the end of this is the importance of Breaking Bad News and why do we need to be good at it, and the basic structure of how to deliver bad news, and some practical tips and some common pitfalls that candidates maybe fall into around this. So why is Breaking Bad News important? And I think the simplest thing to say is that bad news, you break bad news every single day as you're in your job as a doctor, which sounds a bit grim, but it's true. And no matter what specialty you go into, you will break bad news from psychiatry to GP, sexual health, whatever you go into, you're going to be breaking bad news of some description to some people. And I wonder if you've been on a ward round with a consultant who maybe wasn't very good at it, and we know that it can make a big difference. There was a study done a couple of years ago now, I think, around 50% of people who had some sort of bad news broken to them said that they felt it wasn't done well and they didn't appreciate the way it was done. And I think that's partially because, obviously, if you're getting bad news told to you, then you're probably going to have a slightly jaded picture of the person doing it. But also, it's partly to do with our anxieties. When I'm going in to tell somebody that they're dying, or that they've got cancer, or that their relative is dying, you do feel nervous. You do feel kind of hyped up, and you have to try and remember, actually, it's not about me. It's about this person. But it's very hard to not let your own anxieties come across, and that's why having a process that you go through every single time just helps. And it makes a difference to people if you can do it well. And also, it comes up in OSCEs and to pass, which is the most important thing for today. But again, we're all going to be doctors. You're all going to be great doctors, and you just need to be good at this. All right. So, what counts as bad news? And this is the thing that sometimes throws people in OSCEs, because bad news, we don't get to decide what bad news is. I had a patient 2 days ago who didn't even want to know. He was like, I don't care. But some people will be absolutely devastated because they have psoriasis, because it's on their face and they feel unattractive, and that's a psychological. So we don't get to decide. So it's better to go in and assuming it's going to be bad news and breaking it properly than say, oh, yeah, so you've clearly got psoriasis, and actually this person is like in tears because they're psychologically traumatized by having psoriasis. And the approach for all of these things, STIs, telling somebody they have diabetes, telling somebody that they have clinical depression, the approach is the same for all of them. Okay? And again, as I've said about a million times today, you're probably bored of hearing me say it. If you have a process that you go through every single time, it'll make life easier in real life, but also OSCEs will be easier. So, moving on. The structure. So this is what medical schools teach, and it's because in a study in, I think, 2016 or something, a lot of oncologists had come up with this, because obviously they break bad news quite a lot, unfortunately. And there was a big kind of quality study done, and it showed that this process helped people get bad news and get bad news well. So setting, perception, invitation, knowledge, empathy, summary, and strategy. Now, I don't know if I just can't keep things in my head. I always find this, and I still find it very hard to remember. And I also struggle to remember what means what. So what is the perception bit again? What is the invitation? And it's one of these things I feel like they've just kind of yanked it so it makes a word. But if you find this helpful, and I would use this. I could never remember it, so I'm just going to try and streamline it a little bit. So, as I say, that's a lot to remember. So I'm just going to try and streamline it to encompass all the same parts, but maybe make it a wee bit more pragmatic. So setting, I think, is a fair enough thing to think. So setting first. Then, where have you been? Where are we now? Where are we going? Where do we go from here? And that's how I do it. That's when I'm preparing for this. That's what I try and get in my head. setting, where have you been up until now? Where are we now? Which is the kind of Breaking Bad news bit, and where do we go from here? Okay, so hopefully, maybe that'll just make something click a bit for people, because it encompasses all the same parts that I'm going to show you as we go on. So setting is really important in real life on a ward. Again, in an off skate, it's probably slightly artificial in the fact that you'll probably go into a room and the tissues will be there, it'll be quiet, you won't have a pager. So it's maybe just wise to say, before I came into the room, I would make sure that I didn't have my pager. If I was on the cardiac arrest team, I would ask one of my colleagues to be on the cardiac arrest team for that 5 minutes or whatever it takes. So just so you can limit interruptions, because one thing I always think, and I might be getting a bit deep and emotional here, but I'm always so aware that when I'm telling this person that they are dying or that they have a horrible cancer or whatever, I might have told 15 people the same thing this week, but this is their one and only time this is happening, and they're going to remember me for the rest of their life. So you need this to be a good moment, all right? And then there's no real mentee in this session, okay? There's very little interaction. So if you have any questions, please just put it on the chat, all right? So have tissues there. Try not to have them like right in the middle of the room, like, oh, hello, here the tissues are going to cry. I try and have them in a kind of delicately placed situation so that you can present them if required, rather than, here are the tissues. This is the Breaking Bad newsroom. Good luck. So as this bit isn't as relevant to Austin, but it's very relevant in real life, okay? So think about it, say it in an OSCE, say this is what I would want to do. Now we get into the nitty-gritty of it. So where have you been? So keep that in your head. You're trying to ask them, where have you been up until now? Because you may just have met this person as well. If you're on a ward as an FY1, you might have met them twice, but this is actually going on for 10 years or something. So what's been happening up until today? These are just some helpful questions that I use daily. So what has been happening with you up until today? Nice open question, they'll tell you. And then another really useful one, so what do you know about what we've been doing? Just let them answer. Because actually, maybe they haven't been clarified. So maybe you're about to tell them they've got cancer, but they've not been told they're getting tested for cancer. And then that makes it even worse. So you have to make sure that you're on the same page before you launch into this speech about the fact they might be dying. All right, you need to make sure that they're mentally prepared for this. So what's happened up until today? What do you know? And then if they say, oh, well, I know, I've been getting tested for HIV or whatever, say, what tests have we done? So they may say, well, I know we've done a CT scan and we've done some blood tests. And then again, so and why do you think we did them? Because just knowing that we did the test, them knowing that we did the test doesn't mean they know why. So why did we do those tests? And then they'll say, oh, well, you did the CT scan because my liver function was deranged and you want to see if I have liver cancer. Perfect. You know you're on the same page. They may say, oh, you did a scan. Not really sure why. And then that gives us an opportunity to just clarify that a little bit, to mentally prepare them a bit more for what we're about to say. So in a way, I think this is one of the most important parts of the session. Okay, so where have you been? What's happened? What do you know? Why have you done this test? Okay. And that just lets you break into the session. It also gets you kind of calm down as well, I think. Okay, so that's the where have you been section. Where are we now? So this is the big part, and this is the part that is important to, you'll feel the bubbles, you'll feel the adrenaline because you're getting up to this point. And what is important not to do, and it's very easy to do, and I still sometimes do up to today, is beat around that bush. Okay, so in every OSCE station for Breaking Bad News, the key question you have to ask is, do you want to know? All right, because they might come to you, like the guy, I literally had this yesterday on the acute receiving unit. He did not care that he probably had myeloma. Didn't give a damn. And I said, do you want to know the results of the test? No, son. Fine. Fine, okay, we'll just make you feel better. The whole conversation doesn't need to happen. So therefore, if I'd gone in and been like, so Mr. Smith or whatever his name was, you have cancer, he would have been really angry, and that's just awful. So key question, do you want to know? So you know we've done these tests, you know why we're doing them. Do you want to know why? And do you want to know what the results have shown? If they say, and in an OSCE, they're going to say yes, because that'd be a bit of a rubbish statement. Do you want to know? No. Okay, let's just sit here for the next 10 minutes. So they're almost there to say yes, please tell me. And then studies have shown certain things about communication. So there are quite a few studies now that show that a warning shot, this kind of mental preparation, kind of ameliorates things a little bit, makes things a bit simpler for them to process. So you give a warning shot. Again, it's almost always a tick box in this OSCE. So yes, you want to know, okay, well, the tests we've done have come back, and unfortunately, it's not good news. And that's what I try and say. I try and say that exactly. There are lots of kind of different ways to say this. I think, again, just have one phrase that you say a lot, and then it will come out naturally, and it won't sound stunted in the OSCE. So, the tests have come back, and unfortunately it's worse than we thought, or unfortunately it's shown something that we didn't expect, or whatever. In real life, these are all things you might say, but in the OSCE, the tests we've done have come back, and unfortunately, it's not good news. And then, interestingly, a study was done in 2018 that showed saying not good gave people better memories of this moment than saying bad. So rather than saying, the tests have come back and it's bad news, try and say it's not good. So try and use positive words, even if you're then making them negative. Sounds really bizarre. And of course, qualitative research is all about airy-fairy, but it seems to be that this is good. Okay, so rather than saying it's bad or it's dreadful, say it's not good, or it's not what we hoped, or something like that. And then here's the moment that you've all been kind of working up to for the last 5 minutes. Break the news. You have to be direct, you have to be honest, and you have to use real words. So the worst one, and I imagine you'll be taught about this by a palliative care physician, because they tend to have a bit of a bee in their bonnet about this. But don't say stuff like, you may be nearing a stage where you won't be able to recover. What? And you hear this all the time. You hear it a lot in every placement. I'm not sure you're going to get better. What does that mean? You're dying, or you're sick enough to die. I really like that expression, that it's kind of becoming quite normal to say that. You have bowel cancer. You have HIV. Be direct. There's no point beating about the bush. Okay? Don't say stuff like, you have a tumour. It means nothing. And remember, these are usually going to be non-medical people, so you have to use simple terms. Okay, not you have colorectal carcinoma, but this is all stuff you all know. All right, I'm not trying to pretend that you don't. You know all this. You just have to be very direct and say it in one sentence. The tests we've done come back, and unfortunately, it's not good news. You have bowel cancer. Tick, tick, tick. Pass. But thinking forward, we're doctors now. That'll be the best way to deliver this news, because it rips that plaster off and allows them to start processing information. Okay, so setting, we've done that. Where have you been up until now? Where have you been? You're both on the same page now, and then that's allowed you to go forward to the where are we now section. The key question, do you want to know? They'll say yes, and then okay, give a warning shot, you deliver the news, boom. Okay, that's the majority of this station done from a kind of tick boxy point. All right. Hopefully this is all making sense. Again, if you have any questions going through, or you want to ask anything, please just keep going. All right, until then, let's keep going. So we now just have to kind of sit back. And the more you do this, the more you realise at this point there's no right thing to do, and it will change drastically depending on the patient or depending on the relative or whatever. So after I say the news, so whatever it is, you have bowel cancer, sit back, say nothing. Okay, and this is really difficult to do, particularly in an OSCE, because you're aware that you've got this ticking time clock and examiners watching you, and you feel like you're using all this good stuff that you've learned, these communication skills. Silence, golden. All right. You just step back, you sit back, you let whatever's going to happen. Okay. And if you feel that you're about to say something, count to 5 slowly in your head. 1, 2, and see if they've said anything that maybe guided you. Because again, in an OSCE as well, remember these are actors, they will be trained to do this. They'll move you on themselves. Okay, so silence is golden in this situation. Let them cry, let them sit thinking, let them just sit in silence. And it's really hard and it's really awkward. And I love a chat. I love some conversation. I don't like silence in any situation. I tend to fill it, but I really have worked hard, and I continue to work hard to allow silence in these situations. Because also they have so many thoughts and they don't actually care about you at this moment. All right. So sit back, let it happen. And the actor will probably lead you down the next path. So they'll probably ask a question. they'll be like, so where do we go from here, or something. If they don't, what I would do is, after a wee bit of silence, say, does that make sense? And anybody that's worked with me, I think, probably knows I say this constantly to patients, both in breaking bad news series and otherwise. Does that make sense? Because as medics, we have a whole other language, and we have to just make sure that actually we've communicated this properly. So at their cry, 5, 10 seconds. Does that make sense what I've said? And again, they'll probably take that down a route. If they haven't, the next questions could be, do you have any questions? And actually, I should have changed this, because I don't say, do you have any questions anymore? Actually, I wish I could. If I have to do the slides again, I'll get rid of that. What I say now is, what questions have you got? Because they definitely have questions. And do you have any questions? Again, quality research has shown that saying, what questions have you got, makes people ask more than saying, do you have any questions? All right, what questions have you got? And then that will definitely lead you down the right road. The actor will take you down where you need to go. Another thing that you could ask, which I sometimes use, is, what are you thinking right now? What are you thinking about? Because they might be thinking about their daughter who's not going to have their dad, or they might be thinking about their husband who isn't going to handle this information well. How do I tell him? So it's all about just letting it happen. And it's a skill to not be so kind of meticulous about this, that you're getting through these tick boxes, right? I've done my warning shot, I've given the news, and now I have to check understanding. Just let it happen. And you will naturally feel what is best to do. But these are just some suggestions that I have that lead the consultation on. Okay. Hopefully that makes sense. And then where do we go from here? So this is the third part, and this is the part that we know patients don't pay attention to. So after the news is given, they only retain 10% of what you then say. So keep this short and sweet. Don't give them a big long spiel about the intricacies of cancer treatment or antiretroviral treatment or whatever it is. No. What are the next steps? So obviously, hopefully you know what the next steps are. That is the first thing. So if it's a bowel cancer, it's probably going to be, you're going to be referred to an oncologist and a bowel surgeon, or after an MDT. Or if it's HIV, it'll probably be, right, we'll bring you back and we'll test you for other STIs and start you on antiretroviral treatment. Keep it short, keep it sweet. And you won't be expected to know specific treatments at your stage for anything. Just kind of broad terms. So if it is a cancer, say, it's likely to involve chemo, radiotherapy, surgery, or a combination, but that won't be making that decision. And that's perfectly okay to say. And summarize everything you've said, again, just making sure they understand. And that's the breaking bad news process. Okay, it varies massively between different patients, and you just have to kind of learn to go with that. Silence is golden. Okay, so my favorite phrase, does that make sense? And that helps us chunk everything. If after everything you've said, you say, does that make sense? Does that make sense? Does that make sense? You've chunked the information perfectly, and that'll be a tick as well. Okay. So how to conclude these consultations? It can be a bit awkward in real life, particularly because you're sitting there, 5 people have just been told their mum's dying and they're all crying, and you're like, I have 15 other patients to see what I'm going to do. You just have to double check their understanding. Does that make sense? What questions have you got? Answer these questions and then say, right, I'm going to leave you alone with your thoughts. And then here come the bonus points for the OSCE. Here's the name of the bowel cancer specialist nurse. Here's the name of the HIV specialist nurse. Call them if you have any issue. Here's a leaflet or a website for you to go and read about, because you'll forget everything I've just said. Read about it later. And then if you have any questions, call me. Wherever I am, I practice at the clinic, call my secretary and I'll answer them. And you have just delivered bad news as well as you could possibly do it. And that's breaking bad news. Okay. Common pitfalls. How long do I have left? You always get asked it. Just accept that. And you have a bank answer, and I have a bank answer that I say, I have no idea. I usually say something like, well, it's a difficult question to answer. All we have are estimates, and it can be as long as a piece of string. If you know in the OSCE, if you have happened to do an elective in a bowel cancer centre, and you know that it's going to be 6 months, you can say that. If you don't know, it's perfectly okay and actually better to say, listen, I don't want to give you false hope or make this picture seem more bleak than it does already. I don't know. Fine. Using jargon, we're all guilty of it occasionally. Just be aware of it, particularly in OSCEs, and just try not to step into areas not in your expertise. So if you get asked, so what tablets will we put on for my HIV? Again, if you happen to know if you've got an interest in HIV or whatever, fine, tell them. If you don't, say, listen, this is not my specialty, you'll need to be referred to the right people. But I promise, when that happens, you'll get all the information you need. Okay. And then obviously common sense stuff. I don't want to patronise you all by telling you, be empathetic, actively, nod when they say something. Don't like look in opposite directions. But you won't do this. You know this stuff. You've been in medical school for 4, 5, 6 years. You will be able to do this without even thinking about it. Chunk information, you'll do it all instinctively. So the summary from me: breaking bad news is important, but it never gets easier. I've been doing this job for 4 years and I still hate it. But you just have a process. Have a process. If it spikes, great. If that works for you, great. If not, I use this setting. Where have we been? Where are we now? Where to go from here? And you're going to be great. So hopefully we've covered all these things. There are lots of good revision resources again. The Royal College of Physicians in London do a podcast specifically about breaking bad news, which is amazing. So you can listen to that. It's episode 27. It's on Spotify. It's on Amazon Music. All the things. Again, our book, Geeky Medics, has a page on it. It's a bit basic, but that's fine. And PubMed. So there are lots of different methods that have been tried. I would, for OSCE, stick to the method that your medical school has taught you. But for real life, you can look at PubMed to see if there are any new methods that you like. And obviously, if you're on a ward and somebody's about to be told back bad news, ask to go along, and I always take whoever's with me along to let them see how I do it. And then you can learn how to do it, maybe learn how not to do it. I've reached the end of my presentation, so hopefully that makes sense.